Science fiction, honestly, but it is a very real, very heavily monitored clinical reality. The heart isn't just a muscle pumping fluid, you know.
Right.
Fundamentally, it's an electrical engine. It relies on this highly sophisticated, incredibly delicate wiring system to keep that steady rhythm going, minute after minute, day after day. And certain things, even common everyday drugs, can fundamentally alter how that wiring recharges.
Wow. So today we are looking under the hood of that exact engine. We've got this really fantastic high-yield summary by Dr. Fula.
Yes, it's an excellent resource.
It synthesizes the massive 2025 to 2026 AHA, ACC, HRS, and ESC guidelines on ventricular arrhythmias. The vision of this deep dive is to basically decode the electrical misfires of the human heart. We're translating these cutting-edge cardiology updates into a map of how your internal power grid works and, more importantly, how doctors step in when it goes completely rogue.
Right. These guidelines represent the absolute consensus of the world's top cardiology societies, so they give clinicians a master blueprint, really. They outline how to spot the subtle warning signs of an impending blackout and the exact protocols to follow when you literally have seconds to save a life.
Okay, let's unpack this because, we can't really talk about fixing an engine until we understand the types of misfires we're dealing with.
Makes sense.
To start, let's talk about the normal state of things. Usually the heart has a pacemaker at the top sending a clean, fast electrical signal down a specialized highway to the bottom chambers, the ventricles, telling them to squeeze.
Exactly.
But cardiologists look out for a spectrum of chaos that disrupts this, starting with something called a PVC.
Right, a premature ventricular contraction. In plain English, the bottom chamber of the heart just fires early, out of turn.
Okay.
If we look at this on an EKG monitor, cardiologists see what's called a premature wide QRS complex followed by a pause. And that compensatory pause is often what you feel when you think your heart just, skipped a beat.
Why does it look wide on the monitor, though? Does the electrical signal literally get fatter?
Well, it's about speed, really.
Yeah.
Think of the heart's normal wiring system like a high-speed bullet train.
Okay, I'm with you.
When the signal travels down those specialized tracks, it happens instantly, which creates a very narrow, sharp spike on the monitor.
Right.
But a PVC originates outside of those tracks, down in the raw ventricular muscle. So the electrical signal has to essentially bushwhack its way from cell to cell.
Oh, wow.
Yeah, that process takes significantly longer. So the pen tracing the signal on the EKG paper actually has time to move horizontally, drawing a wide, stretched out line.
Oh, that makes perfect sense. So if we think of the heart like a home's electrical grid, a PVC is basically a flickering light bulb.
Yeah, exactly.
It's annoying, maybe a little startling, but usually not a big deal. But wait, when should I actually worry? The cardiology guidelines mention a rule about a 10% burden. If I have a PVC, does that 10% rule mean 10% of all my heartbeats throughout the day?
That is precisely what it means, and it's a huge focus in the 2025 to 2026 updates.
Really?
Yeah. Generally, a few PVCs are totally benign. Most people get them. But if a patient's PVC burden hits 10% or more, meaning 1 out of every 10 heartbeats, all day, every day is an irregular misfire, that takes a real physical toll.
I can imagine.
The heart muscle just isn't designed to contract that way constantly. Over time, that irregular, inefficient squeezing actually causes the heart muscle to stretch out and weaken. We call it PVC-induced cardiomyopathy.
So the heart literally tires itself out from the misfires.
Essentially, yes.
If your light bulb flickers constantly, eventually the whole fixture starts to wear out. So, okay, that's the lower end of the spectrum. Moving up the danger scale, the guidelines outline non-sustained ventricular tachycardia, or NSVT.
Right. NSVT is defined as 3 or more of these premature, wide ventricular beats in a row at a fast rate of over 100 beats per minute. But, and this is key, it lasts for less than 30 seconds.
Right.
The heart races out of control, but the grid manages to self-correct pretty quickly.
It's like a rolling blackout that fixes itself before you can even, find the flashlight.
That's a good way to look at it. However, if a patient already has underlying structural heart disease like, say, damage from a past heart attack, NSVT is a flashing red siren.
Oh, wow.
It is a major marker for an increased risk of sudden cardiac death because it shows the heart has the potential to sustain that chaotic rhythm.
Which brings us to the actual sustained versions, right? Sustained VT and VF.
Exactly. Sustained ventricular tachycardia is when that rapid, dangerous, wide rhythm lasts for 30 seconds or longer.
Okay, so it doesn't self-correct?
No, it doesn't. Or it's so fast that it causes the patient to become hemodynamically unstable, meaning they pass out or their blood pressure drops dangerously low. This is an absolute medical emergency.
Right.
And if that rhythm degrades further into VF, ventricular fibrillation, we have reached catastrophic failure.
The total blackout. The clinical notes describe VF as chaotic ventricular activity with zero cardiac output.
Zero. The heart is no longer pumping. The electrical signals are firing so randomly and rapidly from every direction that the muscle is just, well, it's quivering like a bag of worms.
That's a terrifying image.
It is. There is zero blood flowing to the brain. This is cardiac arrest.
I can definitely see why cardiologists take any wide rhythm so seriously. But wait, what if a patient comes into the emergency room? They're awake, their heart is racing, and the monitor shows a wide rhythm.
Okay.
How do doctors know for sure it's this deadly ventricular tachycardia and not just a benign fast rhythm from the top of the heart that somehow just looks wide on the screen?
Well, the truth is, they don't always know instantly. But the AHA and ESC emphasize a very strict golden rule for this exact scenario.
Which is?
A wide complex tachycardia in an adult must be assumed to be ventricular tachycardia until proven otherwise.
Oh, so you just treat for the worst case scenario right out of the gate.
Always. Treating a lethal ventricular tachycardia as if it were a benign top-of-the-heart rhythm can kill the patient.
Wow.
You never assume the flickering light is just a loose bulb if there's a chance the wiring inside the walls is currently melting, you know? You prepare for a fire.
Yeah, that makes sense. So we've mapped out what these mythfires look like on the monitors. But let's dig into the why. What actually causes a perfectly fine wire to fray and go rogue in the first place?
Good question.
Cardiologists group these triggers into a concept called SCAR-QT. The S stands for structural heart disease. And the most common culprit here is an old myocardial infarction, a previous heart attack.
Right. What's fascinating here is the physical mechanism. When someone has a heart attack, part of the heart muscle dies from lack of oxygen and eventually turns into scar tissue.
Okay.
Now, healthy heart muscle conducts electricity beautifully. Scar tissue does not conduct electricity at all. It acts as a physical roadblock.
So the electrical current comes down that bullet train track, hits the scar, and it just bounces off.
Basically, it gets routed around it. But sometimes it gets caught in the slow-conducting healthy tissue right on the border of that scar. The signal essentially enters a roundabout and starts looping around and around the borders of the dead tissue, firing off a new contraction every single time it completes a circle.
Wow.
We call this scar reentry. That continuous, fast electrical loop is what drives the heart into sustained ventricular tachycardia.
It's like the electrical signal hits a roadblock, gets confused, and just starts doing donuts in the intersection, causing a massive, never-ending traffic jam.
That is exactly what it is.
And the structural category also includes things like myocarditis, which is swelling in the heart muscle. But wait, here's a question.
Sure.
Later in the guidelines, they talk about using a procedure called catheter ablation to fix this. They thread a wire into the heart and literally burn away the misfiring cells.
Yes, very common procedure.
Wait, hold on. You just told me that scars, dead tissue, are exactly what cause these electrical roadblocks. If a doctor goes in and burns heart tissue, aren't they just creating another scar? How does that solve the problem?
I mean, that is a brilliant question. You are creating a scar, yes, but you are creating a highly strategic, non-conductive scar.
Strategic how?
Well, if the electrical signal is doing donuts in the intersection around the old heart attack scar, the electrophysiologist burns a line of tissue connecting that scar to another boundary, like a heart valve.
Right.
They are essentially building a wall across the roundabout. The signal hits the new burn line, can't complete the loop, and the fast rhythm is instantly terminated.
Oh, wow. They aren't trying to heal the tissue. They are building a fire break to stop the electrical forest fire.
Exactly right.
That is wild. Okay, so that's structural damage. But what if the heart looks physically flawless?
Yeah.
No scars, no damage, yet the power still goes out. That brings us to the microscopic triggers.
Exactly. This is where we look at channelopathies, which are genetic defects in the microscopic ion channels on the surface of the heart cells.
Like invisible defects.
Right. Patients with conditions like long QT syndrome or Brugada syndrome have perfectly normal-looking hearts on an MRI, but their electrical wiring has a fundamental manufacturing defect at the cellular level.
And then there are abnormal electrolytes. Low potassium, low magnesium, low calcium.
Right.
It makes intuitive sense. These ions are the actual charged particles carrying the electricity. If your body is depleted of them, the grid fails. But let's get back to what we talked about at the very beginning, the medications.
Yes.
The guidelines specifically highlight prescription drugs as a massive trigger for deadly arrhythmias.
They do. And if we connect this to the bigger picture, we have to look at the QT part of that SCAR-QT concept.
Okay.
On an EKG, the QT interval represents the exact amount of time it takes for the heart's electrical system to repolarize or recharge after a beat. It's the reset phase.
Right.
And certain drugs physically stretch out that recharging phase.
See, I know antiarrhythmic drugs themselves can ironically do this, but the everyday ones are what really shocked me. Macrolide antibiotics, like azithromycin, haloperidol, an antipsychotic, methadone, and ondansetron, which is one of the most common anti-nausea meds given in hospitals.
Yeah, doctors have to monitor this incredibly closely. If you give a patient one of these drugs, their reset phase takes longer. The 2025 to 2026 guidelines state that a QTC, which is the QT interval mathematically corrected for heart rate of over 500 milliseconds, represents a high-risk danger zone.
So why is a long reset phase dangerous? Does the heart just stop?
No, it's actually the opposite. By stretching out the reset phase, you create a highly vulnerable window of electrical instability.
Oh, no.
The cell membranes are lingering in this half-charged state. If a rogue electrical spark, like one of those premature PVCs we discussed earlier, happens to hit the heart during that exact stretched out millisecond, it throws the entire system into chaos.
Wow.
It triggers a highly specific, deadly rhythm called torsades de pointes. The anti-nausea drug didn't damage the heart muscle, it just left the door wide open for an electrical disaster.
That is just terrifying. Since we're on the topic of these stretched out QT intervals and bizarre electrical vulnerabilities, let's shine a spotlight on what doctors call the zebras,
Ah, yeah.
the specific rare syndromes that exploit these tiny defects. Let's start with Brugada syndrome.
Great. Brugada syndrome is a classic zebra. It's one of those genetic channelopathies specifically affecting the sodium channels in the heart.
Okay.
Cardiologists look for a very specific cluster of clues here, including a bizarre coved squiggly line pattern on the EKG in the right ventricular leads. But perhaps the most crucial thing to understand about Brugada is what actually triggers the sudden cardiac arrest.
Right, the clinical notes point out that a high fever is a massive trigger. I have to admit, that sounds bizarre. A high fever. How does body temperature stop a heart?
What's fascinating here is the molecular physics. A patient with Brugada syndrome might go 30 years without a single symptom.
30 years?
Yeah, they are completely unaware of their genetic condition. But if they get a severe flu or an infection that spikes their body temperature to, say, 103 degrees, that thermal heat literally alters the kinetic properties of those defective sodium channels.
Wait, really?
Really, the heat changes how the channels open and close, unmasking the defect and instantly triggering ventricular fibrillation.
That is terrifying.
Yeah.
Just catching a nasty flu could be lethal if you don't know you have the gene.
Which is exactly why the treatment protocol explicitly includes aggressive, immediate fever management with Tylenol or ibuprofen for these patients. They are also told to absolutely avoid a whole list of sodium channel blocking medications, and high-risk patients will usually receive an implantable defibrillator.
Okay, let's talk about the other zebra. Torsades de pointe, which translates to twisting of the points, right?
Exactly.
You mentioned this is what happens when that reset window gets stretched out too far. When cardiologists say the rhythm is twisting around the baseline, what does that actually look like to a doctor staring at the monitor?
Well, imagine looking at a sound wave on a computer screen. In a standard ventricular tachycardia, which is often caused by that scar reentry we talked about, every beat looks exactly the same.
Okay.
The spikes on the screen are tall, uniform, and march out like a picket fence. We call that monomorphic.
Right, because the electrical current is doing the exact same donut around the same scar every single time.
Precisely. But torsades is polymorphic, meaning the shape of the electrical wave is constantly changing.
Oh, so the picket fence is completely warped.
Yeah. On the monitor, the spikes start small, gradually get taller, and then shrink back down again in a repeating pattern. It visually looks like a ribbon twisting around a central invisible wire.
The twisting ribbon of chaos. But why does it twist?
Because unlike a scar, where the signal is trapped in one spot, the origin point of the electrical misfire in torsades is literally spiraling and shifting around the heart muscle.
Oh, wow.
Yeah, the camera, which is the EKG leads on the patient's chest, is seeing the electrical vector from constantly changing angles, and recognizing that twisting ribbon is a massive deal, because the treatment for torsades is fundamentally different from a standard scar-related rhythm.
Which brings us perfectly to the action plan. We've mapped the spectrum, we understand the cellular triggers, we've spotted the twisting lines on the monitor. Now, there's a patient crashing in front of us.
Right.
How do the 2025 to 2026 guidelines tell doctors to save their life? The primary bedrock rule seems simple. Stable equals drugs, unstable equals escheka.
It is the ultimate decision tree in acute arrhythmia management. If a patient is unstable, meaning they have no pulse or their blood pressure is rapidly dropping, you do not have time to wait for a medication to circulate through their bloodstream.
Right.
You must use raw electricity to instantly reset the grid.
The guidelines break down the shock protocols. If they have no pulse, it's full cardiac arrest. You use defibrillation, you shock them, push epinephrine every 3 to 5 minutes, and do high-quality CPR.
Exactly.
But what if they're unstable, dizzy, their blood pressure is dropping, but they do still have a pulse?
Then you perform an immediate synchronized cardioversion.
Okay, what does synchronized mean here?
You are still delivering a massive electrical shock, but the defibrillator machine reads the patient's erratic EKG and times the shock to sync perfectly with a specific millisecond of their heart's cycle.
It's like hitting Control-Alt-Delete on a frozen computer, but you have to hit the keys at the exact right microsecond to force the system to reboot, rather than just pulling the power cord right out of the wall.
That's a great analogy. It forces all the cardiac cells to depolarize at once, hoping that when they wake up a second later, the normal pacemaker at the top of the heart takes back control.
Okay, so if I'm stable, we use drugs. But if we're trying to fix this delicate system with drugs, don't those drugs come with their own risks?
Oh, absolutely.
I imagine pumping heavy antiarrhythmic medications into someone could cause other systemic issues. I noticed the new updates feature a major shift here. Why is procainamide suddenly preferred over amiodarone for stable, uniform VT? Amiodarone has been the holy grail for decades, hasn't it?
It has been the go-to, for sure. But medical guidelines evolve based on long-term outcomes. Amiodarone is incredibly powerful, but it's loaded with iodine and has a massive, highly toxic side effect profile. Over time, it can wreck the thyroid, severely scar the lungs, and damage the liver.
Oh, wow.
Yeah, so the 2025 to 2026 consensus reflects that procainamide given via IV is highly effective at terminating that scar-looping VT, but it functions as a much cleaner tool. It avoids those long-term toxicities, provided the patient doesn't have severe heart failure.
Use the cleaner tool if the patient's condition allows it. That makes total sense. Now, what if the monitor shows that twisting ribbon? What is the specific treatment for torsades de pointe?
For torsades, the absolute first line of defense is magnesium sulfate, usually 2 grams delivered IV immediately.
Wait, even if their blood tests show their magnesium levels are completely normal?
Yes, even if their blood levels are perfectly fine.
Really?
Yeah, we aren't treating a deficiency here. We are using magnesium as a pharmacological shield. Magnesium naturally blocks competing calcium channels in the heart cells.
Okay.
So by pushing high doses of it, you calm down the electrical turbulence at the cellular membrane, which allows the heart's stretched out reset phase to stabilize.
Fascinating. You just chemically force the turbulence to stop. You also have to push their potassium levels up, stop any of those QT prolonging drugs we talked about. And interestingly, the guidelines say to speed up the heart rate using a pacemaker or a stimulant drug.
Right. Think about it. If a slow heart rate stretches out the electrical reset time, speeding up the heart rate naturally shortens it.
Yeah.
You are closing that vulnerable window so the rogue sparks can't get in.
Speed up the engine to prevent a misfire. I love the logic of that. Now, once the emergency is over and the patient survives, how do cardiologists protect them long term? We talked about burning the tissue with ablation, but the major safety net is the ICD, right?
Yeah.
Implantable cardioverter defibrillator.
Yes, the ICD is critical.
It's essentially a tiny paramedic living in your chest, wired directly into the heart, ready to shock you from the inside if the chaos returns. The guidelines detail a strict 35-43 rule for who gets one of these for primary prevention.
Right. This rule is essential for deciding who needs this hardware before they ever have a fatal event. So the 35 means their left ventricular ejection fraction, the raw pumping power of their heart, is chronically 35% or lower.
Because a weak heart is an electrically unstable heart.
Exactly.
Okay, the 40 means you must wait at least 40 days after a heart attack before implanting the device. But if their heart is weak right after a massive heart attack, why wait 40 days? Shouldn't they get the safety net immediately?
It feels counterintuitive, I know, but the data is very clear. When a heart attack cuts off oxygen to the muscle, the surviving tissue surrounding the dead zone goes into a state of deep shock.
Okay.
We call it myocardial stunning. The muscle isn't dead, it's just temporarily paralyzed. If you wait 40 days, that stunned tissue often wakes up, and the pumping power recovers well above 35%.
Oh, I see. If you put an ICD in on day 2, you've subjected the patient to an unnecessary surgery for a problem that was going to heal itself anyway.
Precisely. You have to give the grid time to naturally come back online. And then the 3 means they must be on optimal, guideline-directed medical pills for at least 3 months.
Same logic, right?
Yeah.
Give the medications a chance to remodel the heart before resorting to permanent hardware.
Exactly. It's about exhausting your conservative, non-invasive options before implanting a device that will sit in the patient's chest for the rest of their life.
So let's bring this all together. We've journeyed from a single, annoying, fluttering heartbeat all the way to catastrophic power failure. The human heart is a marvel. It's a self-sustaining electrical grid that beats billions of times in a lifespan without you ever having to think about it.
It really is incredible.
But as Dr. Esafula's breakdown of these guidelines reveals, that wiring is delicate. It can be disrupted by a microscopic scar from 10 years ago, a genetic typo in a single sodium channel, or even a basic antibiotic interacting with an anti-nausea pill.
Yeah, and the overarching theme of the 2025 to 2026 guidelines is precision. They demand that clinicians don't just blindly react to the chaos on the monitor, but systematically trace that chaos back to its molecular origin.
Which brings up a lingering concept I want to leave you with. When we talked about the protocol for cardiac arrest, one of the final steps is to search for the reversible causes.
The H's and T's.
Right. Things like low oxygen, hidden toxins, or